So we are live on the platform now.
Hi, Francesco. Hi, Dr.
Hi,
Mahmoud.
Khaled. Hi, how are you doing?
Great to see you.
Nice to see you. Nice to see you. I mean, it's nice that we just met very recently, all of us.
So how is everything?
I mean, Mahmoud has a problem. I think he cannot hear us properly.
Oh, yeah.
Hello,
I
Farzad.
think... Hi.
Hi.
Hi,
This is
hi, Dr.
from
Mahmoud.
Jordan.
Wait a minute,
Oh,
just مش عارف اسمعكم.
دكتور محمود ما ريستارت الكمبيوتر كله ريستارت الكمبيوتر.
Okay, Farzad, do we know how we can? I mean, I'm not sure how we'll be able to get in touch with the attendees.
Actually, I'm not sure. As Dr. Mahmoud told me, he will present some cases and ask us to make some comments. And I believe maybe the attendees could write in Q&A the questions and we can answer the questions.
Okay.
Dr. Mahmoud, do you want to make comments?
Dr. Mahmoud,
Dr.
yes, says switch off the...
Yeah. Hi, Dr. Mahmoud. I'm not sure if there are any tech guys here to help solve the problem.
Yes, sir. There is an arrow there. Please click there.
There is no arrow here.
Can you hear us?
Stop video. Mute my audio.
No, your audio. Okay, off now.
Yeah. So I believe we will talk about eyelid malpositions. Apparently, Dr. Mahmoud will show us some cases.
What are you talking about? Which
Might
is
be
your
having two options.
Wait a minute.
We can hear you, sir.
It is called mute by audio or stop video. Blur my background. Choose virtual background.
Francisco, I think it might be wise if we can start on time. If you can start maybe with your presentation. What do you feel?
I know, but I mean, is introducing me, so I don't know if people are seeing me or not. I mean, I don't mind. I can start whenever you like. I'm not sure.
Do you hear me?
People, I mean, can anybody in the MEOM team?
Yes, speaker.
Hello. Hi.
Dr. Mahmoud.
Hello.
Hi.
We can hear you. We can hear you, Dr. Mahmoud.
Microphone. Hello.
Yes, sir. The microphone. There is an option named as.
Yes, I opened that. Select a microphone. Yes, I said microphone. Hello.
We can.
You hear me now?
Yes, sir.
Okay. You hear me now?
Yes, perfectly.
Hi, Dr. Mahmoud.
You hear me now?
Can you hear us?
This the speaker phone. I am okay. The speaker phone is okay. Yes.
Dr. Sharif.
الو انا سامعك
السلام
الان.
عليكم.
وعليكم السلام.
How are you doing?
اهلين.
How are you?
Good.
Dr. Samer, Dr. Mahmoud.
اهلين.
Very happy to see you. How are you all?
اهلين الحمد لله.
Good, good.
How are
So
you,
finally, Dr.
everybody?
Mahmoud can hear
Thank
us.
you. I'm
Dr.
sorry
Mahmoud,
for
you
this.
can start maybe.
Fine, fine, okay. Ahlin, I have to welcome you all. Thank you for accepting our participation in this module of this webinar. First, I want to thank Dr. Francisco Corantiglioni from Italy, Dr. Sharif Alwan from Egypt, Dr. Samir Khorma from Jordan, and my close friend, Dr. Farzad Bakdel from Iran. He is the oculoplastic consultant of the MEOM. Thank you all for your participation with us. Luckily, we don't have this retina session. It used to be a retina session in the beginning because of the sponsoring company that imposed that on us. But for one reason or another, they choose to disappear this. So we are lucky, I think. So we can start, inshallah. We have actually this session is one of the 4 episodes of oculoplastic. We had the first one about ptosis. The second one is today, the malposition of the eyelid. And then next week, immediately next Friday, we have the eyelid reconstruction. And lastly, we had blepharoplasty. It will be in the 2nd of June. I'm thankful that you will be with us. I will start now. I will throw some questions, and I would like your comment on the poll of this. Dr. Farzad, you are all right? Okay. With
Hi,
us?
Dr. Mahmoud. I'm here.
Welcome. Okay, alhamdulillah. Good that you are with us. But merely if you're present, I am okay. I feel okay. Thank you, Dr. Farzad. Okay.
Thank
You
you,
are
Dr.
around.
Mahmoud. You may kindly
Doctor?
actually introduce
Yes.
the panelists and speakers, and then we can start the session.
Yes, sure. Fine.
Thank
We
you.
are on time, I think. We are all right.
Yes.
Dr. Francisco Corantiglioni, you will tell us something about the eyelid retraction today, isn't it?
That's true. Thank you very much, Mahmoud, and thank you to all my friends for inviting me. So thank you. I'm very happy to be here. I'll try to
Yes.
show you my screen and getting
Yes.
into my presentation.
Okay. Can you hold it now?
Yes,
Hold
I
it
mean,
now, and I want to start my screen. And I think you will
So-
come after the 13.
okay.
Question. Okay.
So
I will start my screen now. Okay.
okay.
Fine.
Sorry about that. Thank you.
Oh, not at all. Okay. I need a smaller exit. Vale. I'm trying to share my screen. I hope it will be all right.
We are seeing your browser, Dr. Mahmoud.
Okay,
Probably. Okay,
fine.
now we can see your
Okay.
PowerPoint.
Fine.
Now you can start the
Right.
first slide.
Fine. Okay. So, خلينا هو, but just actually that was an introduction that this is the second session of this module actually, and the first question tells you about very basic about horizontal stability of the eyelid margin is essentially maintained by A, lid retraction or lid retractors, B, muscular tone, C, 2-point fixation, D, lid protractors. Can we start the poll, please? This is sure, yeah? all the way from India. Can we have the poll again or what? There is no results. Okay, so fine. Dr. Sharif Alwan, so can you comment on that? I mean, I thought it is straightforward, the question, easy, basic, but you see the results.
Okay, I will comment, but I don't have here the result of the poll. It appeared for a second and then disappeared again.
No, okay,
Oh yeah, now I have it.
okay, it is
Okay,
clear.
a horizontal stability of the eyelid margin is essentially maintained by, and you require a single choice. Actually, protractors have almost no role, but the first three, it disappeared again. The first three, to my mind, have a role. The muscle tone is important in maintaining essential stability. 2-point fixation is again important. And the lid retractors have been shown recently, especially the posterior layer of the lid retractors, to have a major role in maintenance of the horizontal lid stability.
Well, basically, the question is about the 2-point fixation, the lateral palpebral ligament and the medial palpebral ligament holding the eyelid together. The muscle tone comes second and the lid retractors come third. I thought it should be a straightforward question, but it seems it is perplexing to the candidates or whatever.
Well,
fine. Can anybody of the panelists would like to comment on that? Francisco Grattaglioni, you are
Yes, no, but I think it's a difficult question because as has been pointed out, I mean, they all have a role. So, I mean, I think the integrity of lid retractors is important. And again, the muscular tone is very important because if you don't have good muscular tone, even after, for example, a blepharoplasty, then you don't have horizontal stability and you should help it. So I think all are involved. And this is why I think always 1/3 of the audience replied A, B, or C, answered, sorry, A, B, or C to this question.
So it's not that.
I think I take your point and you're right, but still it's not a very easy question.
Yes, yes. So I want to go to the second question. It should be hopefully easier. This is something called epicanthus, but this is epicanthus inversus that occurs when a fold of skin is most prominent in the upper eyelid. B, when the fold of skin is most prominent in the lower eyelid. C, the fold of skin is distributed equally in the upper and the lower lid. D, the fold of skin arises from the caruncle. So can we have the poll, please? Well, I think we are lucky now, at least in this question. Fine. Okay, Dr. Samir would like to comment on, if you are.
Yes, Dr. Mahmoud, yes. Yeah, I think the answer was almost clear. Picanthus inversus, as the name denotes, that it is something which comes inverted. So this is in blepharophimosis syndrome, and the epicanthic fold is raised quite above the median line. So it is Picanthus inversus, and the choice was, it seems it was easy for the candidates.
Okay. And this is the after correction, actually. Now, I want to proceed to the. Now, this third question is about this test of vertical lid laxity due to, first, lateral canthal tendon weakness, B, the medial canthal tendon weakness, C, tarsal weakness, D, orbicularis weakness. Can we have the poll, please? And this is a perplexing question, it seems, and a perplexing choices. So who would like to volunteer to comment on that? Actually, these questions, they come in the board, actually. And
This is why
why
it seems, Dr. Mahmoud, this is why people fail most of the time in the board, because
this is
you
why-
have all the choices are correct. All the
Okay.
choices are correct.
Wait, actually, yes.
I can comment a little bit if you want. I mean, this is a little
Please.
bit tricky because what you see, what you can definitely say, you can say three things from this picture. First, there is a lower lid laxity. There is a disinsertion of the lateral canthal tendon because you see there's an interruption at the lateral canthus.
Yes.
There is not a medial canthal tendon weakness or too much. Otherwise, even pulling the lid downwards, you should see the medial punctum displace a little bit more laterally. And there is a lower lid retractors disinsertion because there is a very deep lower fornix.
Yeah, yes.
But,
and this
but-
whitening, white
Yes.
line. Here,
Yes, the white line is very far, but I mean, then you don't see the tarsus. So, I mean, you may imagine there is tarsal weakness, and definitely is not as a test to test either medial or lateral canthal tendon disinsertion or weakness.
Yes.
So this is
Yes.
why it's tricky. I wonder
yes.
which one you consider the right answer.
So the orbicularis weakness.
Hmm.
It should be the orbicularis weakness because the vertical, actually, lid laxity.
But I mean, this is being pulled. So I think
it could be, but not the tarsal weakness, of course.
yes.
The medial
Dr.
canthal
Mahmoud.
tendon. Yes. Please,
Can I
Dr.
make a
Farzad.
comment?
Yes, please.
Sorry interrupting you. I just wanted to ask if there is time I may make some quick comment here. Do we have time?
Yes,
Yes,
please.
please.
Sure. Yes.
Okay,
Anytime.
thank you, Francesco. Actually, I totally agree with you. There's more than one correct answer here. But I would like to mention this is the vertical. Actually, this is the distraction test. That's one of the essential tests to check for lower lid laxity. One is snap test. The other one is distraction test. Snap test is when you actually pinch the skin and
Yes.
distract the lower lid from the globe and just release it. If it just immediately touch the globe, it's normal. Otherwise, it's abnormal. But this test shows actually laxity when you distract the lower eyelid toward the mid-face and you measure the distance between the globe and the actually medial area, medial spot of the lower eyelid from the globe. If it's more than 7 millimeter, it's considered
Yes.
like a lax lower lid skin. So as Francesco mentioned, the most common reason for aging process and involutional change that leads to lower lid laxity is the lateral canthal tendon laxity. But we have also some part actually a contribution in the medial canthal laxity as well here. And for patients that have long-standing orbicus-ocular weakness, like those with the facial palsy, we may have like abnormal distraction test. So it's more than one choice correct here, but if you want to choose the most actually common one and the role, the most common role of one of these, it can be lateral canthal tendon laxity here.
Fine.
May I comment?
Okay.
Mahmoud?
Yes, please. Yes, sure. Dr. Sharif. Yes.
I'd like to add that I know what you mean when you are saying here that you're testing vertical rather than horizontal stability, because the 2-point fixation at the lateral and medial canthal tendons contribute to horizontal laxity and the orbicularis oculi as well. So I think here you mean that the orbicularis muscle is the weak point, and that is why the lid has been moved that far vertically, not horizontally. Is that what you mean, Dr. Mahmoud?
Yes. Almost close.
Okay.
Yes,
Now,
okay.
if we have another photo with the patient without the lower lid being retracted, we would have better judged the positions of the medial and lateral canthal tendons, and this would have helped more in choosing one rather than the other of these causes.
Right question. Okay, thank you. I think we can proceed into the fourth question. Okay, this is a lady, 35-year-old lady, attended eye clinic complaining of epiphora in her right eye. The most likely cause of this lesion is first paralytic, second mechanical, third involutional, and the fourth is iatrogenic. So can we have the poll, please? Fine. So this is actually a problem that we face in our clinic every now and then. If yes, would like to comment, Dr. Sharif Alwan.
Yes, sure. I am not very sure, but I can see a scar here of lower blepharoplasty, subciliary incision. Am I right?
Yes, that's true. That's true. So
yeah, so here it's iatrogenic. This is because of iatrogenic induced by lower lid blepharoplasty. There's no element of paralysis, otherwise the eyelid would have dropped out of the globe. There is no mechanical reason for this. We can't see any masses. And of course, a 35-year-old lady, this is not involutional. So the choice here is iatrogenic, and actually it is a deep problem. I mean, the problem here is how to correct it. I don't know if you'd like to go into this or
no. We just it's actually, but we ended up in the diagnosis actually, but this is due to excessive removal of skin, of course.
Okay.
What do you see this frequently, Dr. Farzad?
Thank you, Dr. Mahmoud. Can I make actually another comment here before actually answering your question? So I believe maybe we can say like it's a cicatricial ectropion in the lower eyelid, and that's the reason for the epiphora of this patient. I would like to mention in that case that you're seeing lateral lower eyelid ectropion. The patient usually actually says that my tear is coming out from the outside of the eyelid. compared to the patients with nasolacrimal duct obstruction, that the patient may say, I'm just feeling that my tears are coming from the medial part and accompanied by discharge over there. So when you say it's iatrogenic epiphora, you may say, okay, maybe there's iatrogenic trauma to the canal clues, the punctum, to the nasolacrimal, or anywhere through the actually lacrimal drainage system. So I believe maybe we can say it's like ectropion, and then we can say possibly it's iatrogenic secondary to the lower blef. And answering to your question, yes, I'm seeing lots of the patients after actually problems with the lifting, with the blepharoplasty, anything. And yeah, I think the incidence of that problems after blepharoplasty and cosmetic surgeries are rising, at least in the region. So I'm seeing lots of these patients, especially after COVID-19.
Yes.
So I was confused and surprised to see that our plastic surgeries and cosmetic interventions showed rapid rise during COVID-19. And it was actually unexpected, because I believe the patients should stay at home rather than coming for cosmetic jobs, and that things happen much more than before.
Well, perhaps people were very busy taking selfies to themselves.
Yeah,
And this
exactly.
is they would.
Yeah, you're true.
Okay, fine. Okay, I think we proceed. Fine. So, question 5. Regarding this problem, the patient in this picture, is it a stationary disease? A. B. Results from laxity of the canthal tendon. C. Treated by disinsertion of the lid retractor. D. Can occur in both upper and lower lids.
You mean the
So-
problem in the lower lid here?
You know, the problem in the lower lid. It is just ectropion, actually. Ectropion, the lower lid. So I just actually, we want to see what about this problem? I mean, can we have the poll, please? Yes. Okay. Oh, yes. Okay. It's reasonably well done. So, can would Dr. Samir Kharma maybe comment on that?
Mahmoud.
Lower lid.
Yes,
Problem.
this is this is, it looks to me like senile involutional lower lid ectropion, and lower lid retractor disinsertion might play a role. As I can see, the whole tarsus is everted, total tarsal eversion, and it is also accompanied by lateral canthal ligament laxity. I would really address this usually with lateral canthal tightening, maybe with lower lid retractor reinsertion, to make sure that my surgery works well.
Fine. Dr. Sharif would like to comment on that. Is there anything?
Yeah, I totally agree, Dr. Samir, that this is sort of involutional ectropion. And actually, I see that treatment by disinsertion of the lid retractors is an important element in treating this condition. However, it might not be enough. Sometimes we might need a sort of lateral tarsal sling as well. Do you agree to that, Dr. Samir?
Yes.
Yes, I mentioned this, Sharif. I said I will do lateral canthal tightening with lower lid retractors reinsertion combined.
Yeah, okay, right, okay.
Good. Fine, thank you. I think we proceed here. Still we are in ectropion, and this is ectropion has been associated with all except A, medial or lateral canthal tendon laxity, B, orbicularis muscle weakness, C, cicatricial skin changes, and D, tightening of the inferior lid retractors. Can we have the poll, please? Okay. Fine. And this is the pull. Okay, that's it. True. Fine. This is the patient after surgery. It's one of my patients actually. And yes. Okay, can Dr. Francois Corantiglioni is around?
Around, yes, of course.
Yes, okay.
That again, I mean, a bit of a tricky question because it may mislead the audience or, I mean, the attendees. But anyway, of course, we can have a medial and or lateral canthal tendon laxity. We can have orbicularis muscle weakness. We can have cicatricial skin changes, although, I mean, it's not clear from the picture. And of course, we will have loosening of the inferior lid retractors and not the tightening. Tightening, what we should do to cure to cure that. So that's a tricky question, and some,
Okay.
I mean, a few may
but
may be
they are
fooled by the
done,
question. But of course,
actually,
we don't have tightening of the inferior lid retractors. The lower lid retractors will be for sure be loose.
But it was answered okay, and 55% answered this question right, though it is tricky. Fine, okay. So now, this is about in involutional ectropion. The most appropriate statement is, it's one right, A, caused by skin laxity. B, there is a chronic conjunctival inflammation. C, presence of horizontal laxity of the tarsal plate. D, presence of tracheasis. Can we have the poll, please? So this is a tricky again. This is why candidates see that oculoplasty or oculoplastic questions is difficult somehow. So, Dr. Saber Kharma, you were laughing. شو رأيك? What do you think?
Thank you. I think choices B and C are correct because I mean they are talking about different facts about the same problem, that there is horizontal lid laxity, that's true, and there's chronic conjunctival inflammation, that's also true. They are talking about two aspects of the same problem. It cannot be caused involutional ectropion by skin laxity. Definitely, it has nothing to do with this.
Horizontal laxity in tarsal plate. This is the tarsal plate. Horizontal laxity in tarsal plate, and this is wrong.
Yeah, I know the wording.
The wording. This is the trick. The trick or the thing in putting a question, and the candidate sometimes had to look at the things. It's not the laxity of the orbicularis.
Yes.
Not the skin as a whole, but tarsal plate, and this is wrong. Of course, tarsal plate is normal in involutional ectropion. Dr. Sharif, you are examiner for some time. What do you think when putting a question like this?
Yes, skin laxity is totally wrong. Chronic conjunctival inflammation might be right, actually. Yes.
Skin laxity is okay, but tarsal plate, laxity the tarsal plate. But this is where it is wrong.
Skin laxity with ectropion.
The wording. the wording of the questions, sometimes also we have to learn how we put the questions for our
Yeah, sure,
candidate
sure.
somehow. Is it justified
Sure,
that
but
we put such a question? Now, because
actually, the
Mm.
question, yes, the question might have more than one answer, and in this way, the wording must be changed. But there is one point here: chronic conjunctival inflammation is okay, but the more important thing is conjunctival keratinization. That is the thing that occurs, and
that's true.
Tarsal plate, you don't agree to that, and I don't agree as well. Of course, no trichiasis, but no skin laxity as well. There is no. It is not caused by skin laxity. It's rather caused by
Is it?
skin
Orbicularis.
cicatrization.
Oh,
Sorry,
orbicularis
orbicularis laxity.
laxity is mumkin.
So,
Okay.
so the most
Fine.
appropriate statement here would
Is
be B or C. Oh,
B
sorry.
or C.
C, you
B-
said
B,
tarsal.
I
So B is the
most
the answer to
appropriate.
pick up. Yes,
This
but
one.
some say that sometimes tarsal plate softening might be a cause of ectropion, by the way, in some cases of collagen disease. Do you agree to that, Dr. Karantalioni?
Yes, I mean, I think B is definitely the only statement we can say is all right, and I totally agree with you, with all the rest.
Okay.
Absolutely. This is probably seems to be too easy to answer B. That's the problem with it.
Yeah, it's very evident.
Yes, sometimes some are very difficult. Okay, so people might think of, I mean, obviously, skin laxity is not assessed just looking at this patient. Trichiasis is not there. We should see. So there is either B or C. And as Dr. Mahmoud has mentioned, I mean, usually there is no presence of horizontal laxity in the tarsal plate in involution of ectropia.
What do you think, Dr. Farzad?
For a long-standing ectropion, when the conjunctiva is exposed, we may have chronic conjunctivitis and mucoid discharge from the patient. So as Francesco mentioned, what we are seeing here is the conjunctival hypertrophy and conjunctival injection. If you're talking about the other things here, other choices here, I don't think any of them matters here. But it can be said that for this case, we are seeing just chronic conjunctivitis and inflammation here. But I would like to mention that in the case that you are seeing ectropion, based on the etiology, you may see trichiasis, dystichiasis, if you have traumatic or in inflammatory causes for that reason. For involutional cases, as we are seeing other involutional changes in the face, so we may have skin laxity, but skin laxity is not the etiology for ectropion here. And also we may have lower eyelid laxity for sure. One of the components, one of the etiologic mechanisms for involutional ectropion is the lower lid laxity for sure. But what we are seeing here is conjunctival inflammation.
Thank you, Doctor. Just proceed. This is question 8. And they say the techniques available for correction of involutional ectropion include all except. It is A, lateral tarsal strip procedure, B, full thickness wedge excision, C, VY plasty, D, medial canthal tendon application. Can we have the poll, please? Okay, fine. So it's almost straightforward. It looks like fine. And actually, this is the patient with, okay, with it.
Lateral tarsus
And-
length.
Uh-huh. And this is what we mean by medial canthal tendon replication. Actually, when we stitch the medial end of the tarsus to the anterior limb of the medial canthal tendon. Can you comment, Dr. Sharif? What do you
Yeah,
think?
sure. Well, again, the wording of the question as an examiner, it draws my attention. Techniques available. What do you mean by available? Is it the only technique or the chairs in the correction? One of the techniques combined or not? All this is not clear in the heading of the question. But however, the lateral tarsal strip, of course, is important, very important. Full thickness wedge excision, I wouldn't do that. I would do what you're referring in another question to as the Kuntz operation modification, because full thickness wedge excision would result in a scar that is vertically directed and its vector would add to ectropion. So although I agree to shortening of the lower lid, but I wouldn't agree to full thickness. I agree to shortening in 2 layers. VY-plasty is an operation that we do in cases of cicatrization, which is not the condition here. And medial canthal tendon plication is, of course, okay, as you explained. So the one to exclude is VY-plasty.
Thank you, Doctor. Okay, it's unclear. Anybody would like to comment anything? Just we go in. Fine. So, question number 9 takes about a 4-year-old child who has bilateral epiphora. Examination shows eyelashes on both lower eyelids rubbing against the inferior cornea. The parents state that an older sibling has a similar symptom, which resolved without a treatment. What is the most likely diagnosis? A, entropion, B, epiplephron, C, europlephron, D, tracheasis. Can we have the poll, please? Okay. Fine. So that makes us somehow in a better situation. Dr. Farzad, what do you think?
Yeah, a simple case, Dr. Mahmoud. So obviously this is a case of epiplephron. You may see eyelid, lower eyelid, skin and muscle fold over the eyelid and rolling the eyelashes toward the globe. So it's very important to differentiate it from the congenital entropion. That's a totally actually different entity that needs urgent attention, urgent surgery, because it can cause actually corneal ulcer very rapidly, and it doesn't actually resolve spontaneously. So you have put very good keys here. We know that epiplephron, especially in the non-Asian people, resolve actually after the child grows, and that shows a resolution of the symptoms like epiphora after the child grows. And very interestingly, the patient can tolerate that pretty much. And in those cases that show actually keratopathy, we need to do some surgeries, even though the patient is still actually growing. So obviously this is a case of epiplephron here, and I'm not sure if we should talk about the treatment here.
How frequent did you operate on such patient?
Very much, actually. Yeah, because lots of these people are referred, so we are seeing lots of these cases. Very much.
Fine. Dr. Sharif Alwan.
I'd like
Do you see that
to
frequently? Or you operate on these patients?
epinephrine. Yes, I see this is
Yes.
very frequently. Yes, but I don't operate.
Yes. Yes,
I
know.
wait for a while for one important reason. In these infants, the lashes are so soft, they don't injure the cornea, and the condition resolves by itself. So if I see a condition like this, I refer the patient for follow-up in a matter of 2 months, but I don't immediately operate. And this is the condition as well in the element of entropion in cases of blepharophimosis syndrome. We treat the epicanthus, we treat the ptosis, but we don't treat the element of entropion. Do you agree, Dr. Farzad?
Yeah, actually, that's true. But in the case that the patient asks you for cosmetic reasons, you may decide to do more operations. But I totally agree with you that essential surgeries for blepharophimosis syndrome are the 3 things that you just mentioned. And I would like to emphasize again, I'm not sure if I could convey my message correctly. In contrast, the patients with congenital entropion that needs urgent surgery, congenital epiblepharon do not need any surgery unless the patient shows keratopathy, and it's not frequent. So the initial management of patients with congenital epiblepharon is just to observe the patient, not treating.
Great.
Unless the patient,
you.
you stain the cornea, you're seeing keratopathy, the child shows corneal ulcer, like that.
Fine. Okay,
Yeah.
I think we can proceed. Fine. So, fine. Now, this is a 60-year-old man who had paralytic ectropion in the right eye. It's one of my friends, by the way. The most likely surgical procedure he had is one of the following: A, gold weight; B, inner lamella graft; C, horizontal lid shortening with lateral canthus plication, Baron Smith modification, Kunzemanowski; and the D, plication of capsulopalpebral ligament. Can we have the poll, please? So it's a paralytic ectropion to start with. 5, 10. Fine.
This must be very satisfying to you, Dr. Mohammed.
It seems you give them a hint anyway. And now, what about use of these jargons? The name Baron Smith modification of Kunzemanowski procedure. Otherwise, it's actually at the end of the eyelid shortening with excision of skin and the in the outer side of the eyelid. So what do you think about this? There are a lot of names, by the way. When I was preparing this module, I found really one get perplexed with these names. Dr. Sharif.
We used to call this Dimmer's modification of Kund. And if you go to the literature, really you'll find a plethora of descriptions and modifications, sometimes medially, sometimes laterally, sometimes in the middle, sometimes in 2 layers, sometimes with or without plication, and so on. But as an examiner, again, there is a point here. Candidates usually tend to choose the longer answer. If you have 4 choices, one of them is long and the others are short, without thinking the long statement is the correct answer.
Too long to be wrong.
Too long to be wrong, that's right.
Wrong.
But I totally agree to the choice. I totally agree to the choice. Okay.
Dr. Francois Carantolioni, what do you think about these names? There's a lot of names in the literature.
No, it's,
advising this?
I mean, I agree
ectropion?
with Dr. Sharif. I mean, obviously, you need lid shortening. I mean, like, then you can propose another type of lid shortening. I don't do as many lateral strips as I was doing 10 years ago, but this is one, in this case, I would obviously do it. And I agree that if you put, I mean, if you write a very long answer, then even if you don't look at the other answer, they will press C and give it
Not
an
the long
answer.
one.
Yes, probably. I would avoid in the answers gold weight. So we can put either another long answer or another not preferential type of lower lid shortening.
Yes, it looks like very odd. Looks odd. Yes.
Yes. So
That's
where you
true, that's
exclude
true.
that also, then inner lamellar graft, and then you can think about the other two a little bit, but I think this is quite easy. So even
Yes, 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 that's true. Okay, fine. Let's proceed. Fine. Now something else. Now we finished with the ectropion. Now we speak about the involutional entropion. And this is etiological factors in involutional entropion. One is false. A, horizontal eyelid laxity. B, shortening of the anterior lamella. C, laxity of eyelid retractors. D, overriding septal orbicularis muscle. So one is false. Can we have the poll, please?
Forgot the music this time.
No, there is a music. But
Yeah.
sometimes late. Subsequent. Fine. Right. Doctor, who would like to? Dr. Farzad is around?
Yeah, I'm here.
Yes. So what do
So,
you think this question is so easy? Well, difficult.
yeah, it's very easy actually. If you just consider the vector of forces on the eyelid, so if you have eyelid skin shortening, it rotates the eyelid margin outward, not inward. So it's really easy, even though you do not understand the two mechanisms of the involutional entropion that you included there, like horizontal laxity, disinsertion of the lower eyelid retractors, and overriding of orbicularis oculi muscle. And I can add here one other mechanism for involutional entropion, that's enophthalmos. So these are the four basic mechanisms for involutional entropion in patients.
I wonder that the rate of the candidate who answer it rightly are about 50%, 45% only, though it was easy question, you said. So
yes.
this is what it's unusual. What do you think, Doctor?
Yes, it should be higher. I mean, the rate that they should give a higher rate. This is, I mean, what I find out that most people just overlook the eyelid laxity in entropion as opposed to ectropion. And it, of course, as far as mentioned, is one of the most important causes.
Fine, proceed. Fine. So this is this patient has involutional entropion repaired in the left lower eyelid, which involve one of the following. A, reattaching the capsulopalpebral fascia to the tarsus. Second, shortening of the septum. Third, repairing cicatricial changes. D, horizontal shortening of the orbicularis. So can we have the poll, please? In the previous question, we spoke about the pathology of the entropion. Now we speak about the treatment of the entropion surgically. That was answered 45%, and now this is the answer. So can you comment on this, Dr. Sharif Alwan? What do you think?
Yeah, sure.
This is
Yeah, I'm sure most of the participants know that the capsulopapillary fascia is the lower lid retractor, or at least part of it. And shortening of the septum would not share in treatment of entropion, involution entropion. Repairing cicatricial changes, there are no cicatricial changes involved in the pathology of this condition, and horizontally shortening the orbicularis would never relieve the condition. So the treatment is to reattach the capsulopapillary fascia to the tarsus, as there is a laxity of this capsulopapillary fascia. So we help to re-erect the tarsus by reattaching the capsulopapillary fascia that might be disinserted as seen here, or might be just weak. That's it.
I wonder why if they know about quicker suture again. That's the name again.
I may add, yeah,
adaptation.
I may add one point. Well, we used to say or to name quicker sutures as oblique sutures, and we did not know at one time that this is a sort of strengthening of the lower lid retractors. We thought that this acts only by mechanically re-everting the tarsus. But now we know that you are blindly strengthening the lower lid retractors.
Dr. Farzad, can you comment on that? Why is this
Yeah, thank you for
answered
putting
less
that.
than 50%?
Okay, so I will be happy to see the percentage after this session, and I strongly believe that our colleagues could get much more actually correct answers after this session. So I may add here about the kicker suture that is generally a temporary measure. It's not actually a permanent one. So if our colleagues are planning to do some transient actually measurements, for example, if your patient is just bedridden in the ICU, cannot take the patients to the operating room, or you want to quickly resolve the entropion for a while until corneal ulcer is healing, and then go for a permanent one, kicker suture is good. Otherwise, it cannot be considered like a permanent one. And I would like here to mention for the case that to put here, I'm saying that we have kind of ectropion here. So I would like to mention two things. First, if you are planning to correct the entropion in some procedures like base procedure, sometimes you may overcorrect the situation. Otherwise, you may have higher failure rate. And for this special case, I'm not sure if the patient has significant underlying lower eye laxity that maybe in the next stage should be addressed as well. Although I prefer to do it in the same stage.
Dr. Samir.
Farzad, I would like to comment about Farzad, the last statement. My personal feeling is that we can really, that's what I practice. When I have such a miserable involution entropion, and I'm not happy to do WISE procedure and wait how much overcorrection it's going to give me. So I do simultaneous lateral canthal tightening. Since I took that decision, whenever I have lax lower lid with entropion, I combine lateral canthal tightening with WISE procedure. I never had any overcorrection or any failure, in fact. I don't want to say that is a personal modification, but you feel that WISE procedure is everting the lid so much. Why do you want to wait and give him a 1 month trial without really definite hope? I do simultaneous lateral canthal tightening. I felt, I don't know what Francisco would say about this. I felt this really gives a better success rate and peace of mind.
So I
Okay.
would like to mention again, maybe I need to repeat it again. If it was my case, I definitely go for correction of all mechanisms that cause entropion. I was just interpreting what happened in this case. So when I said this patient has overcorrection, I wanted to rephrase what is the cause of the ectropion in the case that was initially entropion. So I would like to add again, if it was my case, definitely I will correct every pathophysiologic mechanisms for this case. Thank you.
Fine, fine.
Dr. Francisco might want
Yes,
to comment.
Yes, I agree with Farzad. I think there are the three, apart from the enophthalmos, which you would leave unless it's too obvious. I think, of course, you should correct all the three causes of entropion. And as I mentioned, in my experience, I usually refer patients in which it was overlooked lower lid laxity. So in this case, probably was not corrected. Well, then, of course, you have to reattach the lower lid retractors, you have to shorten the lid, and you have to avoid overriding of the preseptal orbicularis on the pretarsal orbicularis. So usually, I mean, in the past, what I like to do was an reattachment, transconjunctival reattachment of the lower lid retractors and a tarsal strip. And now what I do is a modified quicker procedure. It is a subciliary incision. And then I do an incision on the orbicularis 4 millimeters below the lid margin to create a scar in between the pretarsal and preseptal orbicularis, and reattach the lower lid retractors by direct visualization. And you shorten the lid at the same time the way you prefer. So you can add the beak or tarsal strip or like a Kunz-Zimanowski pentagon below the skin, and the recurrence rate tends to 0.
great, great. Thank you, everybody. We'll proceed now. What we have now. Fine. So this is question 13. It tells about the surgical treatment of our eyelid retraction due to thyroid associated orbitopathy, TED, which is correct. A, contraindicated in exposure keratopathy. B, can be corrected with excision of molar muscle. C, insertion of a spacer between the molar muscle and the levator aponeurosis. D, it's a lateral tarsal strip procedure. Lateral tarsorrhaphy is the surgical modality of choice. So can we have the poll? So this is really now not the way we wanted, actually, and it's not a perplexing question. I don't think it is, but it seems we want to know more about eyelid retraction now. And this is your turn, Dr. Francisco Carantiglioni.
Thank you.
I'll leave you with to tell us more about eyelid refraction. We want to learn from you.
No, thank
Okay.
you. No, you're too kind.
No, not at all. Okay, you deserve it. Can you share your screen, please?
Yes, thank you.
I'll
Okay,
stop sharing mine.
I'll do it now.
Okay. Please.
Okay, I think you can see it now.
Yes, we can see it.
Okay, so I can a quick talk about the treatment of eyelid retraction, how to manage it. As you mentioned in your slide, I mean, the ocular surface protection is very important, and it depends on the integrity of the eyelids and all the adnexal structures. And we know that there are some features that should be observed, and you don't have to remember all these measurements, 27.1, the length and the height and the opening of the lids, but we should briefly remember that both the upper and the lower lid should cover the limbus by at least 1 millimeter. This is what is considered normal. So when we talk about eyelid retraction, what should we do? Obviously, prevent eyelid retraction, then identify and correct primary eyelid retraction, and correct secondary eyelid retraction. So clinical examination is essential. What we should point out in our notes is the MRD1 and the MRD2. You see from this slide what it is. It is the distance between the light and the upper lid margin, the MRD1, and the MRD2 between the lower lid margin. And of course, you can see what happens if both one or the other are increased. And of course, upper lid retraction is not always, but most of the case, referred to thyroid eye disease. I won't bother you with all the signs of thyroid eye disease, but basically how you identify eyelid retraction when you see that the upper lid or the lower lid is higher than it should be, and when there is this lid lag. The lid lag is when there is no relax of the lid in down gaze, and the eyelid retraction persists when the patient looks down. And this is instead a secondary upper eyelid retraction. You can see that there is a patient with a bilateral upper lid retraction, and you see that the upper eyelid retraction increases when the patient looks up, but there is no lid lag. And why does it happen? So this is not due to fibrosis or hyperaction of the levator complex, so the levator muscle and the mular muscle, but it is due to fibrosis of the inferior recti. So when the patient looks up, there are trains of impulses that are transmitted to the superior recti, and as the superior recti are very close to the levator muscles, there are trains of impulses that are transmitted to the levator muscle. So in the attempt to look up, there is an hypercontraction of the levator muscle. So this is something you should always look at when you examine these thyroid patients. So what should we do for this patient? It depends if it is just in the initial phase or just fibrotic. So in the initial phase, you can try with fillers, with Botox, or with steroid injections. And we have to remember that MABs are not, monoclonal antibodies are not that effective. In the teprotumumab or the new monoclonal antibodies, they will reduce exophthalmos and so lower lid retraction, but are not very effective on upper lid retractions. So how can we manage that surgically? It depends on the amount of upper lid retraction. So if the amount of upper lid retraction is up to 2.5 millimeters, we can use a mulerectomy, as it was pointed out in the slides you presented. Then otherwise, if it is a little bit more, we can use a retractor's recession, or if there is a very evident upper lid retraction, we can go for a full thickness blepharotomy, as you see in the slides. How we perform a mulerectomy? Mulerectomy is an easy procedure. We just invert the lid on a dermal retractor. We just inject 1 milliliter of local anesthetic in between the conjunctiva and the mular muscles, and just we incise the lid at the upper border of the tarsal plate in the upper lid, and then we dissect the conjunctiva and mular muscle from the aponeurosis. So you can see clearly in the image C that there is the conjunctiva, the mular muscle, which is hypertrophic in the steroid patient, and this is the white aponeurosis, and we can excise the right amount of aponeurosis. Then we can leave this to heal spontaneously. I usually use a rapid polyglactin reabsorbable stitches, and you can decide to put a contact lens, a therapeutic contact lens, for a week or two in some patients that might complain about the stitches. And you can see that with a very easy operation that lasts no more than 10 minutes, you can correct both the upper lid retraction in primary position and improve or resolve completely the lid leg. If you have, as I mentioned, more than this, then you can perform an upper eyelid retractors recession. It is like a ptosis. You just recess the levator muscle. And what I usually do, I do an anterior mulerectomy. So it's always better to excise the mular muscle from this patient. And you can have reasonable results with improve of the lid leg, but what you won't get is a good eyelid contour, because with this operation, most of the patients will get a lateral flare. The lateral flare is the fact that the upper eyelid remains retracted laterally. Instead, this is quite good when you want to use, of course, this operation after overcorrection of ptosis, or when you want to avoid skin graft after ptosis and upper lid blepharoplasty, where the levator was advanced too much, or when too much skin was excised. So it's a different matter altogether. When we have a lot of upper lid retraction, more than 3 millimeters, 3 to 4 millimeters, what I would do is an upper lid blepharotomy. Basically, you cut everything in the lid. I start recessing the levator, then I excise the Mueller's muscle, and then I end up doing a full thickness blepharotomy, just preserving bridge of conjunctiva between the medial third and the lateral 2/3 of the upper eyelid, just to avoid a flat upper lid contour. And you can do this together with a lateral wall decompression, like in this case, to improve exophthalmos and cure the upper lid retraction. How would we manage instead the upper lid retraction in seventh nerve palsy patients? With seventh nerve palsy patients, sometimes upper lid retraction is overlooked just because there is a droop of the brow. And so if you don't raise the brow, you won't notice that there is upper lid retraction. Again, we can use temporary measures if we think that the seventh nerve palsy is temporary. So we can use eyelid weights or Botox, again, a temporary tarsorrhaphy or fillers in the upper lid. And you can see how the external eyelid weights are useful, because they just provoke ptosis of 1 to 2 millimeters, and they're very useful as a wait-and-see procedure. They're simply placed in the upper lid, and there are different types and different weights. Of course, when we have to go for permanent measures, you have all these things. So you have the 3 operations that I've already described, but you have also gold or platinum weights to be positioned in the upper lid, or you can inject periorbital fat, autologous fat in the upper lid, or we can see you can use anesthetics or dynamic eyelid reanimation. What do I think of gold weight? I mean, I'm not very keen on gold or platinum weight, because they may become displaced sometimes if they're not properly positioned. And you see that how this patient closes well the eyelids with a gold weight in the upper lid, and you see what happens when the patient rests. So when the patients lay down, the eyelid becomes heavier, and so there might be in some of these patients an increase in nocturnal lag of ophthalmos, which is quite dangerous for the patients. And also, some of these patients may have infection or a displacement. So you can see a patient that is partially extruded. So what I prefer in this patient, as I've shown you before, is an anterior approach muellerectomy. I don't like very much to go from the conjunctival side, just because this patient might have a decrease in corneal sensation and there might be a compromise on the ocular surface. So I would leave the ocular surface intact and I would go anteriorly. And you can see that you can improve very much the upper lid retraction very easily with a very easy operation. Of course, you can use, in these cases, you can go for blepharotomy, as I've shown you before. One interesting thing that I'm just quoting, I never did it myself, is the injection of this local anesthetic in the lid, because it has been shown in this paper that it damages the muscle fibers following injection, and some satellite cells will proliferate and they will form new muscle to replace the muscle fibers that have been damaged. And the proliferation would build up a muscle with greater contractile strength, and this would change for more than 1 year. So, I mean, it's a sort of temporary permanent measurement that can be used in patients that would refuse any kind of surgery, maybe just because they don't want surgery, but because they have bad health or cannot undergo surgery. How do we manage lower lid retraction? So we go now to talk very briefly about lower lid retraction. First, we have to identify if it's due to, if it is in a thyroid patient, is iatrogenic, just post-inferior rectus recession. We have mentioned that the capsulopalpebral fascia, so the lower lid retractors, are very closely related to the inferior rectus muscle. So if we are not very careful when we recess the inferior rectus, this is how we might end up. Or this is another patient who has a middle lamellar retraction following a transconjunctival lower lid blepharoplasty. We always have to remind that a lower lid retraction can be caused even through a transconjunctival approach. Just if we use too much monopolar or bipolar, we can have a contraction and then a retraction of the middle lamella. And this is just to quote an interesting webinar that I had 3 years ago with surgeons from the ASOPers and some American facial plastic surgeons. You see that while for the upper lid retractions, the 3 operations that I have described are quite well codified. So if you go across the world, you would see many surgeons doing the same. For lower lid retraction, everybody says what they want. So dermal, any kind of graft has been proposed. What is sure that, of course, we have to recess the lower lid retractors. We have to do it, but it might not be enough. So while a spacer is never used or should never be used in the upper lid, unless there are very serious reason to do so, in the lower lids, we always will have, or most of the times, we'll have to use a spacer. And which are the best spacers? When I was trained, the best spacer was Harpala graft. Harpala graft is quite good, and you can place it easily in the lower lid. And as you can see, this is a lady that I had decompressed before, and then I did a second stage with a blepharotomy and lower eyelid retractors recession with a hard palate graft, with a nice result in this case. But sometimes with a hard palate graft, you have to go to a second step because it is quite bulky, and you have to excise the thickness through an anterior approach 6 to 12 months following the positioning of the graft itself. So another very good autologous graft and the spacer is dermis, autologous dermis, and you can see you can harvest from anything you like, but of course the problem is that it will lead quite an evident scar. But this is you can have, in my hands, is the best spacer ever, and this is the result you can obtain with bilateral decompression and placement of the hard graft in the lower lid. Sorry, of the autologous dermis in the lower lid. If you don't want to harvest, you can either go for porcine derma collagen implant or acellular derma, which is alloderm, which is now not available anymore in Europe. So it's not approved anymore by EMA, which is the European FDA, so we don't have it. And I use sometimes the porcine dermal collagen implant because you can do it on the local. It's quite easy, but there is some degree of reabsorption. Of course, we don't have to forget that when you have this kind of lower lid retraction, this is due to exophthalmos, so you should go for a decompression first, and then you can do a lower lid retractors recession or pressor spacer at the same stage or as a second stage, like you see in this patient. So basically, in conclusion, let's remember that the ocular surface is dependent on the integrity of the eyelid. This is very important. When we talk about upper lid retraction, we have to be sure that we can manage these three operations. So mullerectomy, upper lid retractors recession, plus anterior mullerectomy, and a full thickness blepharotomy. And when we talk about lower lid retraction, remember that we always, or most of the times, have to use a spacers, and the best autologous spacers are Harpala graft and dermal graft. Thank you very much for your attention. Hope I was not too long.
No, that was great. That was very great. Thank you, Dr. Francois Carantaglioni. That was very comprehensive, clear, explicit. Really, I enjoyed it. Dr. Farzad, would you like to comment on little about Dr. Francois Carantaglioni?
Francesco, I really enjoyed the lecture, very comprehensive. And so I would like to have a look on the Q&A to see if any of the colleagues have specific questions. Otherwise, we may start the discussion. Yeah,
Okay, we will.
pleasure.
Okay,
Mahmoud,
so I
Dr.
can
Mahmoud.
share my, yes, please, Dr. Samer.
Yes, Dr. Francisco, this was really one of the most beautiful talks I ever heard in my life about lower lid or upper lid retraction. In fact, that's truth, really. My question is, when you say blepharotomy, why would you simultaneous levator recession, where, as we learned, that blepharotomy is just full thickness upper lid cut through the whole lid except for the island which you keep in the conjunctiva. Would you always do blepharotomy with levator recession, or was it just for this severe case? Thank you.
Yeah, I usually start, when I do it on the local, because I'm just treating upper lid retraction, I go step by step. So I decided that I might go for blepharotomy, so I start recessing the levator and doing an anterior mullerectomy. Then if it's not enough, I just cut the lateral part of the conjunctiva. And I remember the last two cases were like that. The last two cases I did 1 week ago together, last Thursday, actually. So 8 days ago. And sometimes you have to do more. So basically, I'm not going directly for a full thickness blepharotomy. I try to do a little bit less to be not that invasive. So this is why I start doing that. And I think it's very important to remove the Mueller muscles in all these patients. In the Mueller muscle is very important, both for ptosis and upper lid retraction. I think is the key.
Very tricky. Eyelid retraction is very tricky to manage, actually. Fine. I want to share my screen and go back and try to not to keep you awake all night. Now, fine. So question 14 shows about, by the way, before I start, Dr. Mohammed Al Amri, he apologized today for attending the module. He actually would like to be there in every module, but today he is flying somewhere, and he is, I don't know whether in which plane now. So just I apologized for him, and he is the man behind all this actually activity. Fine. So number 14 question is the shown procedure is used in the surgical treatment of all except ectropion, entropion, ptosis, and lid retraction thing. So it is actually, can we show the bull? It's a medial canthus after repair. Medial canthoplasty to start with, and yes, actually it looks like it's an easy one, and 72% have actually answered it. I don't think we have to stop with this. Anyone would like to comment on this? Fine, so we proceed now. Okay, thank you. Okay, now question 14 is that in the tarsal plate, in the tarsal strip, lateral canthoplasty, the strip is sutured to the opposite eyelid margin, tarsus, B, opposite limb of the lateral canthal ligament, C, the perosteum inside the lateral orbital rim, and the perosteum external to the lateral orbital rim. So where we do suture the lateral tarsal strip. Can we have the pull? Okay. Fine. Dr. Sharif Alwan would like to comment on that. I think the result.
Lateral tarsal
okay.
strip operation is an, yes, thank you, Mahmoud. The lateral tarsal strip operation is two-purpose operation. You can use it either to evert or to invert the eyelid. And of course, we don't go to the opposite eyelid or other side lateral canthal ligament at all. But the question is, do we suture the strip that we create into the periosteum inside the lateral orbital rim or outside the lateral orbital rim? I think myself, I suture it to the outside of the lateral orbital rim as this satisfies me very much on table. Suturing it to the inside would be rather difficult, and you don't have to do that. The vector here of replacement of the lower lid is a horizontal one. It's not an inside one, so we don't have to suture it to the inside of the lateral orbital rim. To the outside would be enough, but you choose the level, whether high or low.
Fine, fine. Okay. Anyone like
Mahmoud.
to comment on that? Yes.
Yes, I want to ask my colleagues, what suture material do you use for catching the tarsus with the perosteum? I feel vicryl dissolve sooner than you need. And I feel proline might stay there forever with the dimple on the lateral canthus. I started using PDS, which is a slow, it's an absorbable, but it takes longer to get absorbed. This is my experience. I want to hear from my other professors.
I myself use Proline, and I use 5.0, and it doesn't make a dimple. Well, some colleagues suggest that this is not enough, and you have to drill the orbital rim. I don't know. This is one more question. You can give us your opinion, Dr. Samer, please. Dr. Samer?
Yes, Dr. Sharif. Well, I think drilling is a very much morbid surgery. Sometimes you really have to do it when lateral canthal tightening was done previously many times with cheese wiring. You have no choice other than doing a little hole and fixating the tarsus to that. I've never done that except in trauma cases with miserable injuries, in fact, few times in my life.
Dr. Farzad, would you like to comment on that? Or with that?
The material you use.
So, yeah, first about the material, my preference is the Prolene. So, actually, it's we can use both absorbable and non-absorbable one. The decision actually depends on the longevity and the weight bearing and the load on the suture. If you have kind of cicatricial ectropion, you have kind of actually large force, and you need to use that weight bearing permanent material. Definitely, you need to use permanent sutures like Prolene. But if you have like an involutional mild changes and you do not want to have like a bumpiness of the knots over the lateral canthal area, especially in the patients with the thin orbiculosucculi and thin skin, you may use actual absorbable ones like Vicryl or PDS. But about when to use drilling of the bone for fixing the lateral canthal tendon, it depends on the integrity of the periosteum over that area. In the patients that have actually poor periosteum or have no periosteum secondary to trauma or tumors or failed previous lateral tarsal strips, you may use bone drilling. It's not a big deal. It's not that much complicated procedure, although it takes a bit more time and you need to use, actually drills hand pieces over there. But for usual cases, you do not need to use a bone drilling unless you have actually lost the periosteum or the bone over there.
Dr.
And
Francesco,
I may make another comment. Sorry.
No, I agree. It's a long question. I mean, which where to place the suture and which, I mean, you can talk to 1,000 doctors in the world and they would tell you different answers when they talk about lateral tarsal strip. I think we were all taught to suture inside the lateral orbital rim, but it doesn't change anything if you suture outside the orbital rim, provided that you put a tight suture. Personally, I don't like Prolene very much. I like the needles of Prolene because as it was born for a cardiothoracic surgery, they have half circle needles and cylindric with a cutting point, but they're automatic. So this is the reason probably to prefer Prolene. But I in my hands, it might stretch a little bit more with time. So I think that PDS it may be a good choice, or I use Ethibond. PDS is a good choice, as Dr. Samara has mentioned, just because it may reabsorb in 3 to 4 months. It is said that it reabsorbs in 45 days, if I'm not wrong, but it takes more than that. And so there is a good irritation, or Ethibond, which is a permanent suture. And what it is very important is to use the right needle that should be either 3/8 or half circle and automatic, just not to, do a cheese wiring in the periosteum. That's, I think, is important more than the type of the suture.
Fine.
Thank you.
Thank you, everybody. That was so comprehensive. Fine. Last question. I actually, one before the two last, actually, I wondered whether I should put or not, because a rare condition, it's called Centurion syndrome. It's a rare condition that presents with epiphora in young adults, is associated with all except A, wide nasal bridge, B, anterior placement of puncti away from the tear lake, and C, abnormal attachment of the medial canthal tendon, and D, treated by plication of medial canthal ligament. Can we have the poll, please? It's a rare condition that we don't see frequently, but we should know about it, and the candidate should know about it. It's not that rare in young adults. So, fine. Well, the answer is actually D. It's not by application of the medial canthal tendon, it's by cutting it. So, Dr. Francois Carantiglioni, do you see Centurion syndrome?
Yes, I see sometimes from time to time. It's not that common. I think if the patients don't complain very much, they can be left untreated. If they do, I mean, there are different options, but there is an anterior canthal tendon release and the plication of the lower lid retractors. I don't like to do it very much, so I try not to do it if possible. I do it if I have to do it. So if the patients complain very much.
Dr. Farzad?
Yeah, I agree, Francesco. Many of these patients have not that much complaint that deserve to do such a surgery. But in the cases that the medial canthus is largely displaced and it looks like there is serious enophthalmos and displacement of the medial canthus, the front may need disinsertion, as you said, of the medial canthus and place it back and make application over there. But we should be very careful about keeping the lacrimal drainage system and canaliculi when you are treating such a patient.
It's a sharing, a cutting of the medial canthal tendon, not application, of course.
Yeah.
The procedure, but actually in the last vociferous meeting in Dubai, they showed a paper where the 50% of cases needed DCR actually with the tube to treat their
following the procedure. You mean following the procedure just
because of
after
the
procedure.
treatment? Yes.
because of the treatment? Yes.
Okay.
I think the canthal area is the most difficult thing in oculoplastic
Yes.
surgery.
Dr.
Always.
Sharif Alwan would like to add anything?
Actually, I see the case, but I rarely treat it. If the patient is living well with the condition, I don't treat it because I don't like to do damage in this area and have to face the lacrimal problems later on. So I see it from time to time, but I try my best not to treat it, except when I have to.
Fine. So the last condition, I think, here. And this patient has a chronic conjunctivitis, upper eyelid that easily evert. What additional feature of this disorder would you expect to be present? A, tarsal biopsy showing decreased fibrillin. B, history of hypoglycemia. C, follicular conjunctivitis. D, history of sleep apnea. Can we have the poll, please? It should be straightforward, easy, I think. Okay, fine. And this is it, actually. Fine. So we just go to the other question, which is related to the same case, actually. And it says the same patient presents with obesity, a soft rubbery tarsus, watery tearing, and a mucus discharge from both eyelids. He prefers to sleep in the face down position. What surgical treatment would be preferred to improve his symptoms? A, horizontal eyelid tightening and canthotomy. Of the lateral canthal tendon. C, canthotomy of the superior limb of the lateral canthus. D, vertical shortening of the tarsus. So what kind of surgical procedure might be done. And this patient, actually, he had the surgery, and you can tell. Fine. So it was also a straightforward. So I think I leave the floor now to know more about
Mahmoud,
floppy
Dr.
eyelid
Mahmoud.
syndrome and Dr. Samer Kharma now. Naam.
Dr. Mahmoud, before I start, there is one single question I want to ask about slide number 4, the iatrogenic ectropion. I mean, we would love to share with our eminent guests how do they manage lower lid ectropion following lower lid blepharoplasty. I know there's a complex problem. This one, Dr. Mahmoud. Dr.
Yes.
Francisco, how do you manage such miserable cases, usually done somewhere else probably, and you are stuck and you want to give a hand to the patient and you are in trouble and the patient is in trouble, the other surgeon is in trouble. How do you manage yourself in such scenarios? Thank you.
Yes, I mean, revision lower lid bleph is very difficult always. I mean, this patient has a problem, a minor problem, but has a problem also in her left lower lid to start with. I mean, that's not too difficult to manage as, of course, I mean, first you have to incise, do a subsidiary incision, try to mobilize everything, see if there is enough skin. If there is not, most of these patients would benefit from actually posterior lamellar graft. Sometimes there is more, with time, there is more skin than we expect. So the thing is to fix the lower lid. I mean, there are several options. First, see if there is enough skin. If there is shorten the lid, raise the lid, do shortening of the lid, and it is not enough, of course, a tarsal strip. We have to do either a mid-facelift or at least an orbicularis flap to the periosteum. What I find, I try to avoid the skin graft as much as possible. So in this patient, I would try to make her accept her left lower lid and try to match the right lower lid to the left. If we are desperate, there is a little bit of upper skin in the left upper lid, so we might use that on the other upper lid here. Here there is a little bit that we can be used as a graft. I would avoid any other type of graft unless we are desperate.
What about injecting of silicone implants? It would take some time, but it will enhance the skin to get, let us say, lax or
yes, that's definitely a surgical problem. And that's difficult. I mean, there is like a memory in the lower lid, so they will tend to drop a little bit more.
Fine. Well, thank you all. I want to unshare my screen so that Dr. Samer Kharma could share his screen. Please, Dr. Samer, tell us more about floppy eyelid syndrome, isn't it? Dr. Samer, can you mute yourself?
Yes, Dr. Mahmoud. Yes, I'm listening.
Yes, please.
Yes, I will. Yeah. Can you see the slides, Dr. Mahmoud?
Yes, now we see it. Yes.
Sure. Thank you.
Good. هنا.
Just 1 minute, Dr. Mahmoud, 1 minute.
Okay, no problem. لا مش هادي لسه قرب على هذه، يعني على اللي افتح السكرين هنا. ايوه yes now we see it all magnified please.
All right, brilliant. Okay, I will talk now a few minutes about this interesting entity, floppy eyelid syndrome. In fact, we used to know very little about this problem, and it is really a problem which was discovered recently, relatively. This is, as the previous slides Dr. Mahmoud showed, the floppy eyelid syndrome. This is a very strange problem in the eyelid, that while examining the patient, even sometimes you do observe that you just manipulate the lid very little and you find that it's easily moving. It's so flexible, more than you usually see. So you start thinking about floppy eyelid syndrome. In fact, the moment the patient walks in the clinic, you see the lash ptosis, which is a very characteristic problem. You can see it on the left side, the lash ptosis. The patient sometimes complains that he's seeing his lashes, which is a very strange oculoplastic problem. Usually, the patient has seen so many doctors, has received so many medications, lubricant, steroids, antibiotics, everything with very little relief. So the problem was really first described in 1981, just 40 years ago almost. Before that, people were not knowing what sort of problem this was. The problem usually comes in patients who are overweight, and really sleep apnea is a very frequent association. Once you see floppy eyelid syndrome, if you ask them, how is your sleep, my dear? He will tell you, I struggle during my sleep. I see nightmares. I wake up during my sleep very frequently because of apnea. Sometimes I sleep during driving, for example. So this is a syndrome, in fact, and usually the pulmonary physician has to take role in the management of his sleep problem, and hopefully it might help the patient overall. As I mentioned, the patient will receive so many medications before reaching the correct diagnosis to start the proper management. Once you do eyelid surgery, if the patient is a floppy eyelid syndrome and you want to do blepharoplasty or ptosis repair, you are in trouble if you did not discover that his lid was floppy, because the lid will continuously be floppy and sagging and ptotic lid with lash ptosis. So you have to really solve the problem from the root before doing any eyelid surgery like blepharoplasty or ptosis repair. In fact, the problem is histochemically well known that there's significant decrease in the elastin material of the tarsus. This is the root of the problem, giving the tarsus a rubbery consistency, and the lid everts very easily during sleep. When the patient goes to deep sleep, his lid is really everted completely, and this gives a very dry atmosphere to the conjunctiva, and you will notice that he has chronic conjunctivitis, and sometimes you will find keratinization very rarely of the conjunctiva of the upper lid. The moment the patient wakes up, the lid touches the cornea with this rough surface of the conjunctiva, and this in the morning, they will definitely, the first thing in the morning, they will remember that once I woke up, my eye was sore, and it was really painful when I woke up, because this rough keratinized conjunctiva with chronic inflammation hits the cornea hard, and this is why the patients really needs treatment. This is not a cosmetic problem. Sometimes they will come with corneal erosion and chronic corneal erosions. You will find in the cornea superficial punctate erosions, especially in the morning. The patient is not happy with his eyes. Once he wakes up, the eye is very sore, he has frequent discharge. Sometimes there is opioid discharge like this, which is a miserable problem, in fact. So this is a medical problem which has to be addressed. If you, even sometimes in severe cases, you will be able to do this pinching for the upper lid without any problem. And I mean, in normal human beings, you will not be able to do all this manipulation. You cannot mobilize the lid this much away from the globe. And the characteristic lash ptosis sign. Once the patient walks in, you will realize an obese patient, most of the time, you will really make a spot diagnosis. This is the proposed management worldwide, almost, removing a pentagon, and you can adjust on the table how much you want to remove by bringing two forceps from this side, and from this side. Once you make your one cut incision, you decide how much you want to align the lids nicely. You want to see how much excess you have, and you mark the other end. And as usual, you have to be cautious, remove less and visit the lid later on, maybe wiser than removing more of the lid and getting in trouble that you cannot bring a whole eyelid from somewhere else. You can combine it with blepharoplasty. You can combine it with ptosis repair. Usually we start with conservative management, lubrication, eye ointment at bedtime, and send them to the sleep study to see him, to make the correct diagnosis. I find most of them, they will really need surgery, and the surgery is really rewarding. It's a minor or a medium-sized surgery. It's not a major thing, and it gives so much relief to the patient. He will thank you so much for giving him relief. You can, I usually use 4O vicryl sutures for the tarsus, so that I need strength for the skeleton of the lid, and then I suture the orbicularis with 6O vicryl. You can use 6O vicryl for the skin, or you can use 6O proline for the skin. The complications of surgery, that sometimes you have wound dehiscence. I usually avoid cauterization in such cases. I give my local anesthesia with adrenaline 15 minutes in advance before starting my surgery, so that I will not need any cauterization, which will cause increased risk of wound dehiscence. Sometimes the wound, if you don't adjust the margins nicely, there might be overlap or notch, so you have to be cautious. Sometimes we need another session to remove more of the eyelid tissue, but it's better to be safe, not to remove so much on first surgery. Thank you so much. I hope it was useful.
Okay, thank you. Yes, it was useful. It was nice and
Thank you very much, Samuel. It
fruitful.
was very
Yes,
informative.
حلوة.
Thank you,
أهلين
Sharif.
دكتور شريف.
Thank you,
Yes,
everybody.
Thank you.
fine.
Thank you, Francisco.
Thank you, everybody, that I enjoyed really this webinar with you. Next week, we have learned from this session and other session. We will start with the presentation by Dr. Sharif Alwan for 15 minutes or so about eyelid reconstruction. And then I will go with the questions as well. And any comment about our performance in this, in this, let us say, session or other session? Dr. Farzad?
Yeah, I think it's very useful. We may include actually a few questions about the management, about the surgical procedures, or put some short videos. I think it can help. Also, I like that discussion, especially in the cases that we have some debates. It's not any straightforward answer. We have great panel here with dear colleagues that have actually great experience in each section. So it's very good to have different points of view on debate cases. And thank you,
Dr.
Dr. Mahmoud,
Franz,
for your wonderful
not at all,
moderation
not
and
at all,
everything.
not at all, not at all. Okay, you are always.
Thank you very much. That was very useful. And I think the younger generation of ophthalmologists would benefit most out of the discussions. So thank you very much.
Inshallah.
Thank
What
you.
do you
Thank you.
think, Dr. Francois, of this kind of webinar? I mean, this kind of dialogue,
No,
learning through questions.
very useful, very useful. I think I would encourage just a young generation to ask more questions and the end and to have a little bit more time of discussions with the young people. But I think very useful. It is just one good thing we learned from the COVID time. So I think we should keep it.
Inshallah.
Dr. Mahmoud,
Thank you very much for organizing. Very interesting.
Thank you all. Thank you all.
Thank you all. Thank you.
Thank
Thank
you
you,
all.
everybody.
See you.
Thank you.
See you,
Bye.
inshallah.
Thank
Dr.
you.
Saber Kharma Sharif Alwan next week will be with us, and we will meet the
Of
others,
course.
inshallah, afterwards.
An honor.
Okay,
An
bye-bye.
honor.
Bye-bye.
Thank
Thank
you.
you.
Bye.
Thank you. Thank you.
Have a nice
Thank
day,
you very
everybody.
much.
Bye.
Bye.
Inshallah. Good
Yeah.
night. Good night.
Bye.
Bye-bye.
bye, everybody.
Bye.
Salam. Thank you. Thank you, Shuriya. Shuriya from India is working very hard. He's